Okay, welcome everyone. I'm so excited to have you here for part one of a two-part series with Jessica and Peño. The series is called Supporting Clients Preparing for Care at the End of Life. And Jessica is the National Director for Clinical Engagement and Education at Compassion and Choices. Actually, one of our Brave members told me about Compassion and Choices, which is Jessica will be able to share more, but is such an important organization in the US that helps to provide education about end of life care and also to do education and advocacy around medical aid in dying. So that's something we'll be talking about in part two. And so just kind of have that in mind. But Jessica, I'm going to hand it over to you to do any additional intros and just get going.
Thank you so much, Jenny. It is such a pleasure to be with you today. Happy Friday. Even though it was a short week, I don't know about you, but I'm still quite happy it's Friday. And really excited to just have a conversation and to be able to support you. Hopefully, maybe help provide few more tools for your toolkit, answer some questions that you may have, but hopefully, maybe there's one or two new things that you'll pick up along the way. Like Jenny said, I'm totally open to questions. Please don't hesitate, especially if there's something I say that's not clear or you want to dive a little bit more into, please let me know. So like Jenny said, we do have all kinds of good stuff to cover and talk about during our time together. So much that we divided it into 2 days for you, because there's always so much on this topic. And really, we could spend an entire day on just one of these things, but we're going to do our best to skim our way through. So today we are going to talk about just kind of some of the general themes and kind of good foundational information for supporting people who are at or approaching the end of life. We'll talk about advanced care planning a little bit and what that looks like. Give you some resources. I got all kinds of resources and QR codes for you. What those important legal documents are. And then, like Jenny said, we will have designated time for questions at the end, but please don't hesitate. Next time we come together, we'll dive a little bit more into some of the supportive programs and services that are most common and available for people at the end of life. We'll talk about some of the challenges and all of that, and of course, more resources for you. But first, I do want to introduce you to Compassionate Choices. If you are not familiar with us, we are the nation's largest and oldest advocacy organization, really focused on all things end of life. That is what we are passionate about, is everything as it relates to planning and having those important conversations in anticipation of care and end of life decisions, but also really advocating to protect and expand the options that are available to folks at the end of life and really throughout their journey with a serious illness. And so we do that nationwide. We work across the country with advocates, with professionals like yourselves, with people that are also very passionate about this, but who might also be working with people who would really benefit from that information and those resources. We do a lot of work not only around education and information and really empowering people to kind of take charge of their own end of life journey, but we do a lot of legislative and legal advocacy work. We have an amazing legal team, a health policy team, who also get very involved in the work that we do from that aspect and that perspective. So, as we jump in, I want to invite you to just kind of take a second, get settled where you are, have a seat, and take a moment to reflect on this thing we call end of life. We all come to this with our own experiences. We've all had our own experiences, maybe in losing someone or supporting someone who has lost someone that they love. Thinking about this topic, we're focused on our clients, but we can't forget ourselves in this. because the experiences that we've had with death and with dying and with loss really do shape and color the way that we show up for our clients. And so I invite you to just kind of think about that for a second. And we want to acknowledge the impact that loss and grief has on us as professionals, maybe losing a client, and on us as individuals. And so these are topics that, although we've been through it personally, um, we are also supporting people in a very professional nature. So I want to just be mindful and acknowledge that as we continue in our conversations here today and in our next conversation. And so part of that, I think it's important to just start with a little foundational conversation around terminology, because especially in serious illness care and healthcare in general, but in end of life care, there's a lot of terms that are often used, not often explained. Some may be very familiar, some are not. So I wanted to just kind of start here and acknowledge that all the language that we're going to be using today is really intended to reflect language related to the final stages of life and support for people that are living with a terminal illness. And so those will describe various aspects of, not just medical care, but the emotional, spiritual, and practical elements of care. So the first is just end of life. We use that term all the time. We abbreviate it EOL, but we don't always, take a second to talk about it and define it. So especially if this isn't an area you work in a lot or not something you've had a lot of conversation about, I just want to make sure that it's clear that we are referring to the final stage of a person's life. I also want to point, this does not assume anything about their disease, their age, right? Because the end of life can come at any age, although we will primarily be talking about adults over the age of 18. And the underlying assumption in that is that this is a death that is anticipated and is likely to come soon due to the diagnosis of a terminal illness. So, in other words, we're not talking about death by suicide and those kinds of more sudden traumatic events. Hmm. When we use the term serious illness, this is generally a condition that impacts a person's daily life, their quality of life, and carries a high risk of death. So usually it progresses along in a way that will ultimately lead to the individual's death. It's usually a condition that will cause like a long-term incapacity. So that might include something like a cancer, but it could also, usually we're talking about it in terms of like a chronic disease that requires ongoing treatment, maybe assistance from others. So they've got care support, maybe family members are involved in providing care and support. Terminal illness is a disease or a condition that is considered incurable and will ultimately result in the individual's death. And this can include a range of conditions. So we can have conditions that are known to not be curable at the time that they're diagnosed, like ALS, like Alzheimer's disease, Lewy body dementia. But it can also be chronic diseases that worsen over time, eventually leading to death, such as things like congestive heart failure. We also, Alzheimer's disease is one of those where it's not necessarily, people don't normally consider it terminal at the time of diagnosis because a person can live with the disease for 10, 20 years. So even within this, the language sometimes is a little fluid and sometimes a little unclear. A terminal prognosis, so that term prognosis means we're basically estimating, it's our best guess that if the disease continues on its normal and expected course, there's a limited life expectancy there. And so when we say a terminal prognosis, usually what we are referring to is now the person is likely to have approximately 6 months or less to live, which is also the criteria for eligibility to hospice. And we're going to talk more about hospice the next time we get together. But a terminal prognosis, when we say that, usually we're talking about 6 months or less. And treatment, although this is a term I am confident you are familiar with, I mention it here because of the different meanings and intentions it can have at this phase in a person's medical care and in their life. Most often, treatment refers to an intervention that is meant to improve a problem, maybe a medication, a surgery, a therapy to control symptoms. Really, we're trying to either cure it or maybe lessen the severity. With serious illness, the focus is often on disease modifying treatments. So it's basically like, how can we extend life? So, what's the next treatment? What's the next option? What's the next medication? And so people end up getting into this fight mode, right? You've heard people talking about battling cancer, right? We like to equate it in that way because it is like that next. What's next? What's next? And so patients and families really get in that fighting kind of spirit, and so do the physicians. So does the healthcare team. So does the family and their support system. And so when they're so focused on a cure and the treatment and what's next and what are we going to do? Is it working? How's it going? What does the scan say? And then it's not uncommon to kind of get to a point where someone might hear, there's nothing more we can do. And that can be a really tough thing. But what I always tell people is there is always something you can do. That is a very problematic statement because at some point, preferably as early as possible, there needs to be a conversation with the patient about what they want. How aggressive do they want to be? How far do they want to take this? What do treatment options look like? But like I said, there will always be things that can be done. The focus is what is the goal of the individual? Because maybe the treatments are going to focus more on comfort and quality of life, and that's what that person wants, not necessarily to focus on a cure. Or maybe a cure is not really an option, but we're focusing on giving them the best quality of life as possible. So, jumping in, then I want to take a second to talk about some of the trajectories that people can experience at the end of life because their path, that trajectory can really vary depending on what kind of disease or condition they are living with. Also, things like social determinants of health, right? Their access to care can also influence some of these things and really shape their experience. And so there's been some really great research out there that has defined these illness trajectories to help us provide kind of a framework and understanding. So if you look at, I think at least for me, what kind of stands out most is that big, bold blue line. And that represents an experience that would we commonly see when somebody is living with cancer, right? Usually they are kind of relatively stable for a period of time. They kind of maintain most of their physical function, followed by a pretty steep decline in their final months, sometimes only just weeks of life, right? And so there's been a lot of intense research in cancer. We're very fortunate to have a lot of information. We have really good staging models. We can predict pretty well. This is why we see more people with cancer enrolled in hospice because that ability to predict this is the path, this is how much time we think you have left, is much greater in cancer. We know how tumors behave. And that is in stark contrast to some of these others. So, organ failure, which is the red dotted line here, looks like a little bit more of a roller coaster because truly it is. So, these are things, right, like your liver failure, your kidney disease, your heart disease is much more erratic. And so, it's characterized by these dramatic kind of ups and downs. And so, the timing of death, the progression of their disease, when that next crisis, that dip, when that next one is going to hit, can be really hard to predict. And it can come out of nowhere, and it often does. If you've worked with somebody or had a loved one who maybe had heart failure or COPD, chronic obstructive pulmonary disorder, is another really classic one because they don't feel that bad until all of a sudden they're in crisis. And so you have these real ups and downs. Um, and then, we also have frailty and dementia. And so that is this kind of green wavy line. So we also have a lot of ups and downs, and sometimes they'll come back up, but they're never fully quite at that baseline where they once were. It's a slow trajectory of decline. But because of those ups and downs, you don't always realize, you don't see necessarily how they're dwindling. And sometimes it's the family member who swoops in from out of town that hasn't seen that person in a while that is the one that realizes, wow, there's been a really big decline here. Because otherwise it's kind of this slow boil because it's progressive, it's insidious, it's happening over a period of years no matter what trajectory they're on. And I think this is really helpful. I've actually used this with patients and families to help validate their experience, to help normalize it, especially with the organ failure and the frailty that's harder to predict, kind of helping them. Really just acknowledge that those ups and downs have been a part of their experience and we're likely to have another one. So what do you want to do when that next one comes, right? Let's talk about that. Let's make a plan because I'm worried that that's going to happen again. But regardless of all of that, for a lot of people, it can feel like this. It feels like they just fell off a cliff, right? Especially if they've been managing for a long time. And as trauma therapists, you know far better than I do the many ways that these experiences can impact an individual and their family and their support system. People can feel like they've failed when they've, hit one of those crisis points. And so, based on a person's experience with getting a diagnosis, even, how fast things moved, their coping skills, their reactions, the support of loved ones, who they were before and during an illness. There could be a lot of things that you are addressing in your work with them. And also, you're going to want to consider, at what point you've entered their life and how that compares to their illness and where they are in that trajectory, right? Or maybe there's somebody that received their diagnosis while you're working with them, or maybe they're seeing you because of their illness, right? And learning to cope with it. So, and then also thinking about all of the other things that people bring with them. It could be addiction, relationship issues, trauma, just general coping skills that they are bringing with them. And so you've got all of that together because this kind of illness will really test a person's coping skills and their internal resources and expose, right, how stress shows up for them. So, just as we respect a person's lived experience, we need to figure out how to meet them where they are, especially if this represents a shift in the focus of your work with them. So, when people are living with a serious illness, when they are approaching the end of their life, regardless of the path that got them here, there are kind of three key things that we know in no particular order people really need at the end of life. And the first is respect. Respect for who they are, for their preferences, their values and their right to make their own decisions. And this sounds simple, I know, right to self-determination, right? We all learned that our first year of school, but it's not as easy as it sounds. People don't always realize that they do have the power to make decisions about their care, that they do not have to do what the doctor said just because that's what the doctor said, right? That's one of the few federal laws around healthcare in this country is that people do have a right to self-determination. So sometimes our job is just empowering them. Sometimes it's making sure that they have the information they need to make those decisions. Another is managing their symptoms, preventing and alleviating any type of suffering. So, of course, we want to focus on the physical pain, but also how do we be proactive and focus our intention on really maintaining their comfort in all ways. And so that support of the emotional, the spiritual, but also the very practical needs is also essential. And this does include caregiver support. right? Supporting the family, the people that love them, their support system. When in end of life care, whether it's palliative care, whether it's hospice, we always talk about the person's support system, whether that's their family, whether it's their neighbor that's coming by to help out. They get just as much of our care and attention and support as the patient does. So the patient may be, kind of the hub of the wheel, but we are supporting that entire system through this end of life journey. And so let's break that down just a little bit more, get a little bit more specific. So, again, keeping in mind that these are just as relevant for the patient as they are their family and their partners and their support system. So, at a very core level, everybody needs encouragement. They need validation. They need to normalize their experience. They need somebody to listen and understand and acknowledge their experience to say, yeah, this does suck. And I'm sorry that you're going through this. And just acknowledging, but also acknowledging that they're not the only one, right? Everybody kind of feels like, yeah, but my situation's different. So, being able from your experience to say, I talk to a lot of people who feel the same way you do. That can be so powerful for them to just hear, like, really? And just giving them that validation can go a really long way. One of the best ways you can do that is to make sure that they have the practical, solid disease information that they need to help them understand what they're living with, and what challenges they face. That is huge. But also helping them build their coping and stress management techniques. I am confident this is what you do every day. But being able to help them, maybe it's establishing a new daily routine, right? Maybe that's where we need to start, helping them focus on what they can do, what they do have control of. Being seriously ill, feeling like that disease is progressing, waking up and kind of having to figure out, okay, how do I feel today? How much energy do I have? Am I going to be able to get out of bed? Can I actually go for a walk? Right? Those kinds of things put tremendous stress on an individual. So helping them build a routine, focus on what they can do, stress management techniques, but also encouraging them to be open about their feelings and focusing on those strengths. You can tell I'm a social worker. I come from that strengths-based perspective. Social support, oh, excuse me, I mean symptom management, making sure that they are comfortable, that we are managing effectively, that we are aggressive. Maybe not aggressive toward a cure, but we are aggressive in managing their symptoms. That should always be a priority. So and not just pain, pain, of course. Pain is one of the most undertreated things, especially in people with any sort of cognitive impairment who may not be able to ask for that daily Tylenol. Even just, menopause, old age, people have these very natural aches and pains as their musculoskeletal system changes. But also we have to think about, restlessness, breathlessness, difficulty sleeping, all of those other kinds of symptoms, that people tend to focus on just on pain, but not those other things. So we want to make sure we're not forgetting about that. Community resources. A lot of times there are so many amazing resources out there, but people don't know that they exist, or they don't know how to access them, or they just feel like mud, and so they struggle to access them, or, just to navigate a complicated system. So this is where your work is so important to help them get connected, or, see what they might qualify for. And maybe just sitting with them while they make a phone call, to help, kind of activate them in that. And then, of course, developing a plan for the future. And we're going to talk a little bit more about that. But thinking about the future, helping them get a plan, going through those what ifs can not only help somebody have that sense of control, can give them the peace of mind, because the important thing is that we want to get them talking about this, right? We want to make sure this doesn't feel like a taboo topic, because especially if they're living with a serious illness, it's not a question of if, it's a question of when they're going to need it. And so, unfortunately, all of this, it can be really overwhelming. It can be a lot for people to find and access, to navigate systems, to manage all this terminology, terms that may be new to them, using insurance in ways that they've never had to use it before. It can be a lot. Especially when you consider that we have a real challenge with health literacy, not only in the United States, but around the world, really. This is a true public health problem. Nearly 9 out of 10 adults, which is the majority of us here in the United States, have difficulty finding, using, and understanding health information. And I'm not just talking about like, how to read labels and the complicated things. I'm talking about their own health information, understanding what's happening in their body. And so the results of that lead to misunderstandings about treatment, poor adherence to treatment plans, right? Have you ever had somebody, have you ever like, this patient is non-compliant? Maybe it's because they didn't understand the information that's being given to them and it wasn't presented in a way that was useful for them. We see health literacy lead to more frequent hospital stays, trips to the ER, longer hospital stays once they're there, mistrust of providers, higher mortality, poor outcomes. I mean, the impact is tremendous. And so, this is something that really is an everyday issue for everyone. And that's why it's so important. And so when you think about all the things that we ask of a person to do to maintain their health, this shows up in a lot of different ways. It's everything from what I choose to have for breakfast in the morning, and is that healthy for me? How does that work with my medications? Am I taking the right medications based on the symptom I'm experiencing? Do I understand that? It's, everything has a patient portal now, right? In order to communicate with my doctor, I can't just pick up the phone anymore. I got to go through the portal, and all my test results are in the portal. And now, I don't know about you, but I'm starting to get AI generated messages from my provider. So when she says, I've reviewed your test results, it's not actually her anymore. It's an AI. And so, right, we have these own experiences with ourselves trying to navigate our own health issues. And so if you think about somebody who is dealing with a serious illness, who is really just feeling like crud every day, this can be a lot to manage. And also, I want to acknowledge if you are, caring for somebody. Katie, I saw your message about your support of your dad, right? You're trying to work, you're trying to help other people, but you've also got all of this going on in your own life. And so think about, all those people out there that, like a lot of us, kind of are that sandwich generation where we're caring for our children, we're trying to launch them into the world, but we're trying to support our parents or our grandparents who, are starting to need more and more help. And so it's a lot to manage. We also have to consider, and unfortunately, we have to really, layer on top of all of that the reality of what people are experiencing in our healthcare system. And I know there's a lot to look at here, but basically the racism, the homophobia, the gender bias, right? A lot of us here appear to be female, and I don't know about you, but you go to the doctor and they're like, "Oh, it's how are you sleeping? Is it stress?" You're like, "No, I'm not okay right now." Right? Those kinds of things are just overlooked, ignored. The homophobia, people that don't feel like they can be their authentic selves when they are communicating with their healthcare provider or their healthcare team. That is the opposite of helpful. And then you add on that the insufficient access, the lack of services, rigid systems, the eligibility criteria, insurance, right? It is tremendous. And the other thing, too, is the research has shown us that even people who are highly educated at times of stress, in times of illness, their health literacy plummets because they are now forced in this situation of having to navigate and figure all of this out. And just because someone, Jenny, I'm looking at your comment and I'm thinking about this, just because someone survived, right? We see that on the news, right? Oh, they survived, they're going to be fine. but we don't really take the time to think about how has their life truly changed. They might have survived that accident, but what if they are now in a wheelchair and their home has to be modified and their medical bills are tremendous as a result? They can't go back to work, right? Yeah, we see these things all the time. And so I know in your work, you're used to unpacking all of that. So this may be a reminder, but I hope if nothing else, it's kind of that validation that you are on the right track with that. You know, more than anything, these barriers that we see not only impact a person's stress, their trauma. We see generational trauma, generational mistrust, right? We have entire populations of people who don't believe in going to the hospital because they fear the type of care they get or the care they won't get, right? They feel pushed and led toward a specific way, or people living with disabilities who are, forced to function in an ableist society and feel like people are just trying to, maybe convince them to do certain things or not pursue certain treatments because what's it matter? You're disabled anyway. That's not okay. And the result of all of that is people have poor pain control and symptom management. There's higher likelihood of hospitalization. Again, people aren't getting the kind of care they want, and just not everybody has access to a trusting, open, honest care team. And unfortunately, that is the reality. So when we are supporting them, yes, Bethany, thank you. Yes, yes, people who fear deportation, who fear ICE, and that's not just people who don't have the legal documentation, right? We are seeing people with green cards, with citizenship, who have gone through the process that also are fearing that. I think we all are getting to the point where we have stories of people we know who've been stopped at the airport, passports taken, American passports taken, and detained for hours with no explanation. Yeah. So when we are supporting folks, we need to honor who that person is and what their experiences have been and how they show up, right? And where they're at. And so thinking about what we can do to create that space for them and give them an opportunity to talk about, the history of mistrust or the mistreatment that they've experienced, or ask them, right? Open that door for them, practicing humility of not making any assumptions. Maybe people haven't had any problems. Great. What do we want to focus on? But creating that space for people. So how do you welcome, not just accommodate upon request, but how do you proactively support their abilities, their communication needs, and other preferences that may be different than your own? Are you addressing people in the way that they wish to be addressed? Whether that be pronouns, titles, or other honorifics, right? And so certain cultures and communities, you need to make sure that you are using the Miss or Mrs., that you are referring to them as doctor. They worked hard for that degree, even though they've been retired for 30 years. You still refer to them as doctor. And so asking somebody, right? We can ask, how would you like me to address you? How would you like to address me? Because also that is important. And with the context of end of life care, right, how are we avoiding assumptions about what is preferred? A lot of times we see comments about, people who are suffering with dementia. That one gets me the most. Why do we assume they're suffering? Most people I know with dementia are really quite content. Their family might be having a hard time because they're the ones seeing the changes. But there comes a point in someone's disease where they don't know that they don't know anymore. Now, they might be suffering because you're not proactively giving them a daily Tylenol, and those aches and pains are making them agitated, right? Or somebody is, suffering with another disease or suffering with behavioral health challenges. We can't make those assumptions. And also, similarly, when it comes to end of life care, what a good death means. A good death is different for everyone. And so, asking somebody, what does a good death look like to you? What does that mean to you? Does it mean you want to be at home surrounded by people with music playing and candles and aromatherapy and the dog at the foot of the bed? Or does it mean you prefer to be in a hospital room by yourself with monitors so that, you can see what's going on? All are okay. I want to pause because I know that's a lot of information. And we covered a lot of ground, a lot of heavy stuff. I just want to pause for a quick second before we jump into a little bit more of the logistics and mechanics here and see if there are any other questions. Still
I
with
ha-
me?
Yep, I haven't seen anything in the chat that you've missed. This is just
Okay.
all so on point and resonant, though. It's just awesome.
Okay, great. All right, so let's talk about advanced care planning. The conversations, the important forms. We're going to go through this kind of quick. So, advanced care planning is the term that we use to refer to this process, and it is meant to be a process, ongoing conversations. This is not a one and done. The process of planning for future healthcare, future decisions about healthcare, so that we can hopefully respect and honor an individual's wishes and preferences and values if they are unable to communicate their own wishes. For whatever reason, that could be due to cognitive impairment, it could be temporary, it could be permanent, it could be due to injury. But this process of having the conversation is what's really important. Now, we do hope that through that process, we fill out some certain forms. We're going to talk about those in a second. But really, it's the process of having the conversation that is the most important part. A lot of times people just focus on this very perfunctory act of filling out the forms, and that really isn't what we want to focus on. And I can't underscore enough that the conversations and the benefits of those conversations are many. And we do have a lot of good research that tells us, I will acknowledge we have research that suggests, advanced directives are flawed. Yes, they are, because they aren't always honored or people don't know, or people haven't updated them. And not to blame people, our systems don't always honor them. EMRs don't find them and pull them up quickly. We don't have time to do that in the ER, or we don't take the time. So it's not a perfect science, but that again is why having the conversation with the person, because hopefully this process involves choosing a person, that is where the true benefit really comes from. So we also see, in addition to all of these things, right, it can reduce admissions to hospitals, it improves quality of life, it can also improve the bereavement experience of families because they felt like they knew how to make decisions, they knew how to honor what their person wanted. It can also impact moral distress among healthcare staff because they, again, have that comfort of knowing that this is what their patient wanted, right? It shouldn't be up to anybody other than the patient. So as a part of this process, there are some forms that we hope get filled out. And one of those, the biggest of those, is an advance directive. Now, an advance directive is a legal document that generally has two sections or two main components to it. One is instructions for medical care if they're unable to communicate. So that's where we see like their resuscitation preferences. That's where we see preferences around maybe artificial hydration and nutrition. Maybe I don't want surgeries anymore. I don't want to go to the ER anymore. That's kind of that one big section. The second section is then choosing a healthcare agent. And so choosing that person to make decisions, they're your go-to person to speak for you, to help out when you are unable to make that decision if that time comes. Now, in different areas, this is called different things. So here in California, we call it a durable power of attorney for healthcare. Other states call it a healthcare proxy, a healthcare agent. You might hear surrogate. There's a lot of different terms, but really what we're talking about is the same thing. This is a person who has been chosen to make decisions on behalf of another. Now, they do not become the guardian. They do not become responsible for finances. They don't even, it doesn't even give them access to finances because in every state, there is that kind of separation of healthcare decisions and financial affairs. I do also want to comment that in every state has their own law when it comes to advance directives. There are no federal laws when it comes to advance directives, other than the right, you have the right to do one. So every state has their own form, and this is something that's important to be aware of. There is some reciprocity among the states, but it's not always reliable, especially when you could come down right to that point of an emergency. So if you have somebody who maybe lives in multiple places, right? They split their time between different states, or they travel frequently, or they live near a border where they live in one state but they're getting care in another state. It might be worth considering having more than one advance directive just to cover all the bases and make sure that we don't run into issues with their advance directives being honored.
And Jessica, do you
Yeah.
recommend that people have these in paper form, like on them, with them, easily accessible?
Yes, thank you. So, yes, the most important thing, so after an advance directive is completed, everybody needs a copy. Do not let somebody lock it up for safekeeping, put it in the drawer, put it in the safe deposit box. Everybody needs a copy. An advance directive is no good if nobody knows what it is. And waiting until there's an emergency to go find it and pull it out, that's not a great idea either. So the person that's been chosen as the agent should have a copy. The patient should have a copy, but they should also be giving it to their doctor, their healthcare team, hospice team. Everybody should get a copy. Also, advanced directives need to be updated. They should be updated at least every few years, but if there's been any, changes in relationships or changes in healthcare status, we want to see updated advanced directives. A lot of healthcare entities prefer 5 years or less, but that doesn't mean your advanced directive from 10 years ago is going to be invalid. Megan, I see you. Want to chime
Hi,
in?
sorry. Hello, everyone. I'm Megan, by the way. I work with Jessica.
This is my
I
right
just
hand right here.
I just wanted to pop in because I just did a webinar on proxies. Just to pop in to say that also on those advanced directive forms, most states have at least one like additional person that might sign that, that's like a witness, or kind of like a backup. And so making sure those folks also have copies is really important. I think at this point, Jess, you could tell me if I'm wrong, I think most states have like, it's like your proxy signs it and then there's like at least two other spots that you can have with another loved one or something. So those people are also great people to make sure they have copies, because
Yep.
we want to make sure they're ready to go if needed.
Yep.
Oh, so
Yeah,
they're like
absolutely.
backups.
Yeah, so they call it an alternate. So that
Mm.
way if the primary person is unavailable, unwilling at the time, then it's kind of that next person. Now, the tip with that is do not let somebody choose two. Like if they have two kids and they can't choose between their kids, so they have co-agents, that never works. Always a bad idea. So I would encourage, and this is where the conversations come, right? Because you want to be able to say, this is what I want. This is what's important to me. When the time comes, are you going to be comfortable making that decision for me? No? Okay, well, then I'm going to talk over here. People assume it needs to be a child, a spouse, a partner, a family member. Sometimes that's not the best person, right? So, this is where having not only the information about how all of this works, but those conversations about what's important really, really matters. And there's a lot more that we can talk about on that, but in the interest of time, I'm going to keep going. I saw there was a question about Pulse. So, a post, and this is another one of those things that is different by state. There is a national post coalition. Their website is awesome, post.org. They have a lot of really great resources, some cool videos that explain the post and explain decision making and such. But usually, if it's whether it's a post or a MOLST or I just one state, Kansas, Missouri, has a TPOP. We just learned about that. But for generally, it's referred to as a post. It's usually on Pulsar pink paper. Yes, photocopies that are not pink are just as valid. But this is different in that it is designed for people with a serious illness. It is designed to get a little more specific about things that are likely to come up at the end of life, like code status, artificial nutrition hydration, and basically your preferred intensity level of care. And this is designed to go with the patient wherever they are. And because it is completed in conversation and in partnership with a provider, a licensed medical provider has to sign it in order for it to become valid. Once they do, it is now considered a valid medical order. And so that's why we refer to this as a portable medical order. So it applies in a skilled nursing facility just as much as it does in the ER. The other thing I want to point out is this form I have here is a California form, but this is true in most states. You'll see that it has the EMS symbol in the corner. Because this is a signed medical order, this is one of the few things that is valid should 911 be called if EMS is at the home. So let's say somebody's having an acute event and the patient's wishes are DNR. They don't want resuscitation, right? They don't want that CPR. You can wave an advance directive in their face. You can show them a bracelet all you want. It doesn't matter. They are required to begin CPR. And let me tell you, once they start, they can't stop. Breaking ribs, they will do everything that they have to do to get the pulse back, get the breathing going again, right? It can be really traumatic and incredibly painful. A post is the only way that a person can legally say, this is what I don't want this, right? Or I do, right? Here's a medical order saying, yes, please do this. So whenever somebody has completed a post, again, we want to make sure everybody has a copy, but we want to make sure that it is in a very visible, obvious place. So whether that is with a magnet on the fridge, on the back of the front door, somewhere that's very easy for everybody to see in the event of an emergency. That's really important. Unfortunately, not a lot of people are completing their advance directives. 2 out of 3 adults in the United States have not completed an advance directive. And unfortunately, this is a statistic that hasn't really changed in at least a good 10, maybe 20 years. And we know that certain communities, racially and ethnically diverse populations, are even less likely to not only document their end of life wishes, but to have those conversations. Again, think about, what it takes to have the conversation. You need the information, you need that trust, you have to feel comfortable asking, and it's really not happening. So there are a lot of tools out there for facilitating these conversations. And I'm aware of time, and I apologize, I'm going to fly through these a little quickly, but you'll get the slides. And number two, each of these has a QR code on them. So if you want to learn more and get this actual resource, you can do that as well. So one of the things we really want to focus on, we can't plan for everything, but having an understanding of a person's wishes, priorities, and their goals for care is the important first step. So finding out what are their wishes, what's already been decided, what's already been done, right? Do you have the documents? Well, how long, right? If somebody says, I got all that taken care of, I have an advance directive, great. When's the last time you pulled it out and looked at it? Is it still what you want, right? What's unclear? What needs to be discussed and decided? So this is where we really gives us a good place to start in having these conversations. And then there are some amazing tools out there that you can look at. So the Conversation Project, if you're familiar with them, has the Conversation Starter Guide. And it really breaks down, kind of like what does a good day look like for you? What brings you joy? Who supports you during your difficult times? This is an amazing way to start a conversation, and it's available online as a PDF. People can print it out. You can give it to them as homework if you're a fan of homework. Thank you, Megan. People can fill it out. It's kind of a fill in the blank kind of tool. Really great. There's also the Serious Illness Conversation Guide that really focuses on how to have these conversations. This is really helpful, especially in a clinical setting where maybe we need to deliver some news. We need to have a conversation, maybe about the progression of the disease, right? That kind of thing. And so, really focusing on how are we setting up the environment? Do we have all of the right people there? Starting with what do they know? What do they understand about their situation so that we then know where to go. But also making time that we're stopping in the middle of that to listen, to respond to the emotion, to let people ask questions, that it's not just, the professionals talking the whole time. There's also a model that I'm a big fan of. This comes from palliative care, a communication framework there called I Wish, I Worry, I Wonder. And so I wish really allows you to kind of align with their experience, with their hope, while being able to be truthful and sensitive and express kind of concern. And then being able to offer a nice subtle recommendation. And it once you kind of get the hang of it, really it can be all in one sentence, right? So for example, you could say, I wish we could reverse this heart disease, and we will continue to look for ways to treat your condition. But I worry that you and your family might not be prepared if things don't go the way that we hope. I wonder if we could discuss what's happening and what matters most to you right now. Would that be okay? And that's a really nice way to just align and start that conversation. And I want to take this opportunity to say, in all this time, I keep talking about the patient, the family, their loved ones, the caregivers. Please don't forget the children. Kids know when things are going on. Kids, a lot of times, in the spirit of protection, right, that we're protecting the kids, we don't include them in conversations. We don't tell them what's going on. We don't give them a chance to ask questions and understand what's happening. So, yes, please make sure that we are including the children. And this is a really great way to show them that this is not a taboo topic, that this is a part of life. We want to do it in an age appropriate way, of course. So, depending on their age, I mean, I've used things like The Lion King, right? Dory and Finding Nemo, those kinds of things can be a really great example for kids. Of course, there's a million books out there. There's a lot of tools and resources that you can use. Um, I see, Bethany, your comment about death cafes. There's a lot of people that do fun things like death and desserts. Um, uh, um, um, Megan, help me, I'm blanking.
Death over draft.
Death over drafts. Thank you. Death over drafts is a really fun one where you meet up in a brewery, and it is about breaking those taboos around death that, sometimes it's more of what we think than what it is. Sometimes things are a lot bigger in our head than they actually are. And thank you for sharing that, Bethany, because that's a really great comment there. Also, it's not uncommon for conversations about the end of life and healthcare wishes to also involve, I mean, we hope they involve, right, spiritual, but also sometimes religious beliefs and practices. And so the Amen protocol, not as widely known, but really great. It was developed years ago. It is also evidence-based and has research behind it to really help bridge the gap between hope and faith and healthcare. And so it can help reframe conversations into ones of hope because there's always hope, but sometimes what we're hoping for shifts, right, as the disease progresses. People think sometimes that signing up for hospice means you've given up hope. I beg to differ. It means we're looking at hope in a different way. Really quickly, there's also some really fun card games out there. The Death Deck is my favorite. Really fun and awesome way to get conversations going. And then we also have a lot of great resources. Like I said, I'll send you these slides. These are some great organizations with training, resources, tools. And of course, we have tools and resources as well. These are completely free workbooks to help people plan for future conversations as well. I did not do a very good job of leaving time for questions and conversation. I am so sorry about that.
No
But like
need to
Jenny said,
apologize. This
I
has
am
been,
I am available. I will be seeing you again. And so please don't hesitate if there's something that we can help with.
and for anyone here, this will be on the replay too. If you have questions, you can always send them to me in preparation for next time as well, so we can respond to your needs that way too. And I'll have all the links, all the things up on the replay. And for all of our Brave members, I'm going to create in our resource hub area, just like a place where we can have all the links to access easily. This has been amazing. Just thank you both so much. This is just awesome.
Yeah, you're very welcome. It was definitely our pleasure. I hope it was helpful. And I look forward to seeing you again.
Well, thank you. And thank you, Katie, for that. I'll add that to the replay too. I'm going to include all the links that were shared
Mhm.
by folks on the call as well.
Yeah, and we can help Jenny with some great tools as well.
Well,
Yeah, Jenny, if you want any of this, any of our stuff that we can download in PDF and send your way to make it that much easier, I'm happy to do that.
Yeah,
okay, I'll let you
the
know.
Dougie Center for kids is amazing.
Yep.
Mm,
Lots of grief and bereavement support there as well. That's
okay.
often my go-to.
Okay. Megan, I see you grabbing something. Are you grabbing that link too?
Yeah, I was like, I'll pop it if they're
Yeah.
local to me here in Portland. I love them. I'm somebody with like childhood grief that never got addressed, and the Dougie Center helped me as an adult. So I think they're
Yeah.
incredible.
In Houston, I don't know if you are familiar with this. We have Bo's Place. Have you heard of Bo's
Hmm.
Place? So
Hmm.
that's another good one. I'll
Not
add
sure.
that. It's just
Awesome.
Bo's Place.
Okay.
It's another good, it really focused on kids, but they also do a lot of adult work too.
Hmm. Hmm.
There we go. Thank
Okay.
you.
Yeah.
I already had a million tabs, and now I'm going to
You're
keep them all
welcome.
separated over here so I can add them into the replay. All right.
Thank you.
Well, thank you so much, everyone. Happy Friday. We will see Jessica again in 2 weeks. And then actually, a few weeks out, 2 weeks after that, we have another training on traumatic grief with another expert. So it's like that one just happened, but it's like this kind of perfect little
Perfect.
lineup
Perfect.
series. So yeah,
Perfect. Yeah, and if there are specific questions or things you want to touch on, I can always adapt next time to make sure that we touch on those things
I'll
too.
let you know. All
Okay.
right. Bye,
Thanks, everybody.
everyone.
Bye.
Take care.